I'm happy to introduce Dr. Emily Lau, who will be our grand round speaker today. She's speaking to us from MGH. She originally grew up in Diamond Bar and then went to Brown University for medical school. Also received a MPH from the T.H. Chan School of Public Health at Harvard. She did her medical training at internal medicine at Brigham and Women's Hospital, and also was the chief medical resident there, and then went to MGH for cardiology and also advanced echo fellowship. She's been specializing somewhat in, or she has been specializing a lot in sex-specific risk factors and characteristics of heart failure. And she's the director of the Hormone and Menopause Cardiovascular Diseases Clinic at MGH. So thank you very much, Dr. Lau, for joining us, and we're excited to hear what you have to speak to us about today.
Well, thank you very much for that very kind introduction, Chris. I'm just going to start by sharing my screen. Can you all see that okay?
Looks great.
Excellent. Well, thank you. I'm so delighted to be presenting to UCLA, which in many ways feels like is my home growing up in the Los Angeles area. And I'm particularly excited to be here talking about a topic that I'm really passionate about, which is sex differences in heart failure with preserved ejection fraction. And today, I'd really like for us to consider whether HFPEF in women actually represents a disease of her own. Here are my disclosures. So as we all know from caring for patients in the clinic and in the hospital, heart failure with preserved ejection fraction is a really major public health concern today. HFPEF is now the leading form of heart failure, and its incidence and prevalence continue to rise. And one of the most striking features of HFPEF is its female predominance. Displayed here are data from a study of 712 participants from the Framingham Heart Study who were hospitalized for new onset heart failure. And what you can see here is that among clinical risk factors, including atrial fibrillation and a history of coronary heart disease, female sex was the strongest risk factor that actually distinguished heart failure with preserved ejection fraction from heart failure with reduced ejection fraction. And since this study was published, this observation has actually been replicated in many subsequent analyses. Now, despite a similar lifetime risk of developing heart failure in both men and women, the prevalence of HFPEF is markedly higher in women compared with men. In fact, about 55 to 65% of women in heart failure registries have HFPEF. And among HFPEF hospitalizations, women outnumber men 2 to 1. Differences in cardiac structure, adaptation to physiologic stress, and comorbidity burden have all been proposed to explain this female susceptibility to HFPEF. So here's our roadmap for today's talk. First, I'll explore sex differences in HFPEF risk factors, which may explain why and how women are more susceptible to developing HFPEF. Second, we will discuss HFPEF in women and consider the question, does HFPEF in women represent a distinct phenotype? Third, we'll review therapeutic implications of these sex differences. And finally, we'll end with an examination of mechanistic insights. For this talk, I'll be using the term sex to really represent biologic sex assigned at birth, and I'll reference it as a binary variable. Most clinical studies actually use self-identified gender as a proxy for biologic sex. So in that context, we'll use the terms male and female and men and women interchangeably. Now, I acknowledge that this approach really doesn't capture the complex interplay between sex and gender, which really is an important topic that deserves its own dedicated series of talks, but out of the scope of today's discussion. So let's begin first by unpacking how cardiometabolic disease contributes to female susceptibility of HFPEF. While HFPEF is an increasingly common clinical condition, mechanistic understanding is very limited. The current prevailing paradigm proposes that HFPEF is actually a comorbidity-induced pro-inflammatory state. So this paradigm that was first proposed by Walter Paulus and his colleagues proposes that unlike HFrEF, which is really driven by a loss of cardiomyocytes in the setting of myocardial infarction or other insult, HFPEF is a systemic disorder. Under this paradigm, cardiometabolic risk factors such as obesity, hypertension, and diabetes induce a pro-inflammatory systemic state or systemic pro-inflammatory state. An activation of the inflammatory cascade is then thought to lead to microvascular and endothelial dysfunction, impaired nitric oxide signaling, and increased production of profibrotic cytokines. And together, these changes all ultimately converge to induce hypertrophy, interstitial fibrosis, and the clinical syndrome that we all know to be HFPEF. So with that framework in mind, I think it's notable that across all studies of HFPEF, including epidemiologic studies, registries, and clinical trials, women with HFPEF have more comorbidities than men. Here are data from about 4,500 women and 4,000 men enrolled in 3 trials of HFPEF: Charm Preserved, iPreserve, and Top Cat Americas. And as you can see, women with HFPEF were older, more likely to be obese, and hypertensive. On the other hand, men with HFPEF had a higher prevalence of atrial fibrillation and coronary disease. Now, if we tease out these specific risk factors and look at the associated heart failure risk with conventional risk factors like hypertension and diabetes, we actually see that there are a lot of notable sex differences. For example, in community-based epidemiologic studies, hypertension portends a 3-fold greater heart failure risk in women compared with 2-fold greater risk in men. And diabetes was associated with a 5-fold greater heart failure risk in women compared with 2.4-fold greater risk in men. Our group was interested in this concept, and we examined the role of obesity in HFPEF pathogenesis in healthy men and women. And we did this by leveraging an international collaboration from 4 longitudinal community cohorts: Framingham Heart Study, MESA, PREVENT, and the Cardiovascular Health Study. And among 28,000 healthy participants from these 4 cohorts, we found that obesity and insulin resistance were significantly associated with risk of future HFPEF, particularly among women, as you can see here in the red solid line in the cumulative incidence plot. These data highlight the importance of obesity and other cardiometabolic risk factors in contributing to the development of HFPEF in women. Now, why do conventional risk factors more strongly predict HFPEF development in women compared with men? To start, the typical pattern of age-related cardiac remodeling differs in women and men. Female hearts adapt to a lifetime of pressure overload differently than male hearts do. And in particular, pressure overloaded induced hypertrophy in women is really associated with much more accentuated concentric remodeling and more pronounced diastolic dysfunction, as you can see here in the top panel. Whereas in men, this type of pressure overloaded hypertrophy is really marked by both concentric and eccentric remodeling, as you can see in the bottom panel. This phenomenon has actually been shown consistently in epidemiologic studies. At earlier ages, men have greater absolute values of LV mass and wall thickness. But with advancing age and adjusting for body size, women experience a more accelerated increase in LV wall thickness than men. And here are data from over 4,000 Framingham Heart Study participants with serial LV echocardiographic observations across a 16-year period. And I think you can appreciate there's a steeper increase in LV mass with advancing age in women. But I think what's most notable is actually the interaction between cardiac aging and exposure to traditional risk factors. So using the same Framingham Heart Study cohort, investigators looked at longitudinal trajectories of LV mass in men and women, and they stratified that by burden of traditional cardiovascular risk factors like smoking, hypertension, diabetes, and obesity. Women and men who had higher cardiovascular disease risk factor burden actually had higher baseline LV masses and greater increase over time compared with those with lower cardiovascular disease risk factor burden. I think what's more interesting is that women in both groups had slightly steeper slopes later in life compared with men. Together, these data highlight that cardiovascular adaptation to physiologic stress and comorbidity burden is really unique in women and likely plays a significant role in the development of HFPEF in women. Not only do women remodel differently than men in response to traditional risk factors, we're beginning to understand that female-specific factors also contribute to HFPEF pathogenesis. For example, hypertensive disorders of pregnancy, including preeclampsia and eclampsia, were found to predict risk of hospitalization related to HFpEF. As you see on the left-hand side, in a study of over 2 million women with delivery hospitalizations between 2006 and 2014 in New York and Florida, women with a history of preeclampsia or eclampsia were 2 times more likely to be hospitalized for HFpEF within 10 years from delivery, compared with women who did not have a history of preeclampsia or eclampsia. Separately, our group examined whether infertility, which is an under-recognized reproductive risk factor, was associated with future risk of heart failure. Although infertility is underappreciated with respect to future cardiovascular disease risk, it affects about 15% of US women. And we found that among 38,000 women who were enrolled in the Women's Health Initiative, infertility was associated with a greater risk of heart failure that was driven exclusively by greater risk of HFpEF. And notably, this association did not appear to be explained by traditional cardiovascular risk factors or infertility-related factors. I think the natural question is why? Well, there's been some suggestion that vascular function, including things like arterial stiffness and endothelial function, may be abnormal in women with hypertensive disorders of pregnancy and infertility. Endothelial dysfunction and arterial stiffness have both been shown to be important contributors to HFpEF pathogenesis, and perhaps they are the unifying link between these reproductive risk factors with HFpEF. But more to come on this in the future. While women are more vulnerable to developing HFpEF, are there marked differences between men and women once an individual has actually developed HFpEF? And I argue that the answer to that question is yes. Women with HFpEF have more clinical evidence of congestion and lower self-reported quality of life compared with their male counterparts. These are data from a combined analysis of charm-preserved, eye-preserved, and TopCat Americas that compared signs and symptoms of heart failure in men and women with HFpEF. And what you can see here is that women with HFpEF displayed in red reported greater orthopnea, PND, peripheral edema, and RALs compared with men who were displayed in the blue bars. JVD was more commonly reported in men compared with women with HFpEF. And what about quality of life? Women with HFpEF reported consistently worse quality of life compared with men. And specifically, they reported lower KCCQ scores and higher Minnesota living with heart failure scores in clinical trials, both consistent with lower quality of life. ECHO also seems to tell us that men and women with HFpEF are different. Compared with men, women with HFpEF have lower LV masses and volumes, higher LV systolic function, and greater impairment of LV diastolic function, including lower E' and higher E to E' ratios, even after adjustment for important clinical covariates, including age, race, ischemic heart failure etiology, and prior MI. What about biomarkers? They also seem to tell us that the HFpEF story may be different in men and women. Sex is actually known to impact circulating concentrations of both BNP and NT-proBNP. And in healthy populations, circulating levels of natriuretic peptides are actually 2-fold higher in women compared with men. But interestingly, the opposite is true among patients with HFpEF. Across large randomized trials of HFpEF, including TopCat, charm-preserved, eye-preserved, and Paragon-HF, NT-proBNP was consistently lower in women with HFpEF compared with men. And this is particularly notable given the higher baseline levels of NT-proBNP that we see in healthy women compared with men. Now, the mechanisms really to try to understand this relative natriuretic peptide deficiency in women with HFpEF have not been sorted out, but several hypotheses have been proposed, including lower wall stress due to smaller LV cavities and reduced LV compliance in female HFpEF hearts. What is actually driving these sex differences in signs and symptoms, as well as quality of life? We tried to answer this question by examining hemodynamic responses to exercise in 121 men and 174 women with physiologic evidence of HFpEF, ascertained by level 3 CPET in our MGH-CPET database. In this analysis, we found that men and women actually exhibited similar exercise limitations as measured by peak VO2 and percent predicted VO2. What we saw was that men had a peak VO2 of about 15.5, which translated to 68% predicted peak VO2, and women had a peak VO2 of 14, equivalent to 66% of the predicted max VO2. To put this into context, the peak VO2 of a patient who's eligible to be listed for cardiac transplant is less than 14. So these patients are pretty limited. Now, despite a similar functional capacity, women performed worse across all exercise domains. In particular, women exhibited worse peripheral oxygen extraction, RV and LV contractile function, and diastolic response to exercise compared with men. We also looked at sex differences in arterial stiffness and tried to understand their contributions to abnormal exercise responses in women with HFpEF. And as I mentioned earlier, impaired endothelial and vascular function have both been proposed to contribute to disease pathogenesis in HFpEF. Previous studies have actually shown us that women have greater arterial stiffness at baseline compared with men, and that might be one of the reasons why women are more likely to develop HFpEF. So in this study, we compared baseline measures of arterial stiffness, including augmentation pressure and index and aortic pulse pressure in men and women with HFpEF. And first, what we found is that resting measures of arterial stiffness were significantly higher in women compared with men with HFpEF, as displayed here on the left. And then second, we found that arterial stiffness was actually associated with abnormal LV diastolic responses to exercise, as measured by pulmonary capillary wedge pressure to cardiac output ratio in both men and women, but the associations were stronger in women. I think what these data show us is that arterial stiffness may contribute to phenotypic differences that we see in men compared with women with HFpEF, and it really implicates the vasculature in disease pathogenesis of HFpEF in women. Now, I think one of the most interesting observations is that despite the fact that we see that women with HFpEF exhibit more symptoms, greater functional limitations, and worse quality of life compared with their male counterparts, clinical outcomes are actually better in women. These are, again, data from the combined analysis of Charm Preserved, iPreserve, and Top Cat Americas. And what it shows us is that the risk of cardiovascular death and all-cause death was lower in women compared with men, and that there was no difference in the rate of first heart failure hospitalization between men and women. So I think it's fair to say that men and women with HFpEF do seem to be fundamentally different. And the natural next question is, do women with HFpEF actually represent a distinct HFpEF phenotype? Displayed here are data from a study of almost 400 patients with HFpEF and these patients underwent detailed clinical, laboratory, EKG, and echocardiographic phenotyping. Using hierarchical cluster analysis and model-based clustering, the investigators identified 3 distinct groups with markedly different clinical characteristics, including measures of cardiac structure and function, invasive hemodynamics, and outcomes. What you can see here is that there's group 1 represented a younger group of patients with moderate diastolic dysfunction and relatively normal BNP. Group 2 included obese diabetic patients with a high prevalence of OSA and worse LV relaxation. And finally, group 3 included older patients with significant chronic kidney disease, electrical and myocardial remodeling, pulmonary hypertension, and RV dysfunction. And I think if you look over here and look at the outcomes, what's really interesting is that group 1 actually had the best survival free of cardiovascular death or hospitalization, while group 3 had the worst outcomes. And then the really interesting observation is that women comprised over 2/3 of the participants clustered in groups 1 and 2, highlighting the possibility of female-specific HFpEF phenotypes. So this idea of a female-specific HFpEF phenotype has been observed in other phenomapping studies too. This here is an analysis of 300 HFpEF patients, where investigators again employed hierarchical clustering of patients, and they did that based on obesity and inflammatory biomarkers. And this time they found 3 phenotypes that they labeled pan-inflammatory, non-inflammatory, and obese high CRP. The pan-inflammatory phenotype had more comorbidities and heart failure hospitalizations. And overall biomarkers, including NT-proBNP and fibrosis markers, were higher, and exercise traits, including peak oxygen consumption, 6-minute walk distance, and active hours per day were worse. The non-inflammatory phenotype had the most favorable values for all of these measures. And then the obese high CRP group resembled the non-inflammatory phenotype, except for isolated elevation of CRP and lower functional performance. And again, you can see here that women comprised 63% of the participants in the obese high CRP group, compared with only 45% of the participants in the non-inflammatory group. I think what these data show us is that they're consistent with previous studies that demonstrated the really unique contribution of obesity and inflammation to HFpEF pathogenesis in women. And it really supports this idea that comorbidity-driven microvascular inflammation is a very important pathophysiologic mechanism for women with HFpEF. So far, we've reviewed sex differences in HFpEF susceptibility and clinical phenotype. Are there therapeutic implications of these sex differences? I think we're all aware that HFpEF represents a very significant clinical challenge, largely because we have no effective or very few effective HFpEF-specific targeted therapies. This highlights a greater therapeutic gap among women given the higher prevalence of HFpEF in women compared with men. On top of that, the systematic underrepresentation of women in clinical trials further limits the pool of evidence that we have to guide therapeutic strategies for women with HFpEF. Despite these challenges, post-hoc analyses of 2 HFpEF randomized control trials have hinted at potential therapeutic benefit of specific therapies for women with HFpEF. Here are data from the TOPCAT randomized trial of spironolactone in individuals with HFpEF. And as you all remember, in the TOPCAT trial, treatment with spironolactone was not superior to placebo in reducing the primary composite outcome of cardiovascular mortality, aborted cardiac arrest, or heart failure hospitalization. But post-hoc analyses found a really interesting signal by sex. While there was no difference in the primary outcome by treatment arm between men and women, there was a clear heterogeneity by sex when examining all-cause mortality by treatment arm. Specifically, spironolactone was associated with reduced all-cause mortality in women, but not in men. Now, what are the mechanisms that might explain this finding? That's not known. Some animal studies have shown a greater impact of mineralocorticoid receptor antagonists like spironolactone on cardiac remodeling in female mice compared with male mice. And in these studies, they've also seen that MRAs may normalize myocardial gene expression profiles post-MI preferentially in the female mice. These experimental results suggest in the context of TOPCAT post-hoc analyses raise the possibility that female hearts may demonstrate greater myocardial sensitivity to aldosterone. It really, however, was not until the publication of the Paragon-HF trial that fueled substantial interest in understanding sex-specific responses to therapy. As a reminder, in Paragon-HF, treatment with angiotensin receptor neprilysin inhibitor sacubitril/valsartan did not reduce the primary composite outcome of total hospitalizations for heart failure and cardiovascular death in patients with HFpEF. Notably, in pre-specified subgroup analyses, there was a suggestion of heterogeneity with possible benefit in 2 groups: patients with lower EF, defined as an LV ejection fraction less than or equal to 57%, and in women. And as you can see, treatment with sacubitril/valsartan was associated with reduction in the primary outcome compared with valsartan in women, but not in men, with a significant P for heterogeneity of less than 0.005. And when we tried to break this down further, when examining outcomes according to sex, the benefit from sacubitril/valsartan in women with HFpEF was attributable to a 33% reduction in heart failure hospitalizations in women with a P for interaction of 0.0046. So one hypothesis that has been proposed to explain these sex differences may be related to inherent differences in normal ejection fraction between men and women. Normal EF is generally considered to be higher in women than in men, and there's been some suggestion that systolic dysfunction might actually occur at a higher LVEF range in women compared with men. So, for example, maybe an EF of 52% is actually abnormal in women, but normal in men. Displayed here are data from a pooled post-hoc analysis of both Paradigm-HF and Paragon-HF, which randomized sacubitril/valsartan to patients with HFrEF and HFpEF respectively. And as you can see from this line, benefit of sacubitril/valsartan persisted to higher EFs up to 60 to 65% in women, displayed in the red line, compared with men, displayed in the blue line. Notably, however, effect modification by LVEF on the efficacy of sacubitril/valsartan was similar in both men and women. Further studies are really needed to tease out whether LV ejection fraction alone or whether other mechanisms such as sex-based differences in neprilysin inhibition may explain the notable sex differences in treatment outcomes with sacubitril/valsartan. These data do, however, highlight the need for us to think about sex-based EF ranges when we consider the efficacy of sacubitril/valsartan in clinical practice. Finally, in 2021, the publication of the Emperor Preserve trial brought us the first effective targeted therapy for the management of HFPEF. Emperor Preserve found that SGLT2 inhibitor empagliflozin significantly reduced cardiovascular death or heart failure hospitalization in patients with HFpEF or mid-ranged EF. And then Emperor Preserved was followed closely by the DELIVER trial that was released just earlier this year, which found similar reductions in cardiovascular death and heart failure hospitalizations with dapagliflozin. Unlike sacubitril/valsartan, there was no suggestion that the effect of SGLT2 inhibitors in HFpEF is modified by sex, as demonstrated by comparable reductions in cardiovascular disease and heart failure hospitalizations in both men and women for both empagliflozin and dapagliflozin. Finally, I'd like to spend the last part of my talk exploring potential mechanisms underlying sex differences in HFpEF. As you recall, at the beginning of the talk, I highlighted this leading mechanistic HFpEF paradigm that proposes that HFpEF is a comorbidity-induced pro-inflammatory state. An important link between cardiometabolic risk factors and cardiac structural and functional changes is actually systemic inflammation. Immune responses are known to differ between men and women. And I think the classic example that really illustrates this is the female preponderance of autoimmune disease. So that begs the question, can sex differences in immune response actually explain differences in HFpEF between men and women? We tried to answer this question by studying 71 cardiovascular protein biomarkers in over 7,000 healthy participants from the Framingham Heart Study. And what we found was that 86% of these biomarkers actually differed significantly between men and women. And interestingly, we found that biomarkers that were overexpressed in women, shown in red to the right, were enriched for biomarkers involved in inflammation and obesity-related pathways, while biomarkers overexpressed in men, shown in blue to the left, were enriched for biomarkers of fibrosis and platelet homeostasis. We then tried to really explore the role of inflammation in HFpEF pathogenesis using lipidomic profiling. Our research group has an ongoing effort to study eicosanoids, and eicosanoids are bioactive lipids that are derived from arachidonic acid, and they regulate the upstream initiation of inflammation in humans. We quantified 890 of these eicosanoid metabolites in the plasma of 510 patients who underwent detailed physiologic phenotyping with an invasive CPET test at MGH. And we found that 70 of these specific eicosanoids were associated with HFpEF status. We then hypothesized that many of these metabolites may actually highlight important inflammatory pathways that may be involved in HFpEF pathogenesis. For example, we identified this one metabolite called 8,9-EPETE, which is an epoxidation product of eicosapentaenoic acid. And what we found was that it may, in fact, mediate the association of higher BMI with HFpEF. Now, are there differences in eicosanoid levels between men and women? Well, we tried to answer this question comparing levels of eicosanoids in men and women, both in the general population, so healthy participants, and among participants with heart failure. And as you can see here, we found that there are marked differences in circulating levels of eicosanoid metabolites between men and women. This is a volcano plot displaying multivariable adjusted associations of sex with eicosanoid-related metabolites in over 5,000 healthy participants enrolled in the MESA study. And we found that among 811 metabolites assayed, 45% of them were actually very different, significantly different in men and women. 248 of those metabolites were higher in women, as you can see here in the pink diamonds to the right, and 117 of them were higher in men, shown in the blue diamonds to the left. We did the same exercise, but this time looking in heart failure patients, specifically HFPEF patients from the MGH-CPET database. And we again found vast differences in pro and anti-inflammatory eicosanoid metabolites between men and women, with metabolites that were enriched in women displayed in red and eicosanoids enriched in men displayed in blue. These analyses are very much ongoing and there remains a lot of work to do, but the preliminary data highlight the role of systemic inflammation in HFPEF disease pathogenesis, especially in women. Now, no discussion on sex differences is complete without a consideration of menopause and sex hormones. So what is the role of menopause and sex hormones in HFPEF? While the higher prevalence of HFPEF among older women and greater susceptibility of postmenopausal women to develop LV diastolic dysfunction has led to the hypothesis that menopause-related estrogen deficiency may actually be an important contributor to HFPEF pathogenesis. We've already discussed how the heart adapts differently in men and women. As you recall, female hearts are more likely to develop LVH in response to hemodynamic stress. But what previous studies have also shown us is that lack of estrogen enhances LVH, whereas menopausal hormone therapy or treatment with estradiol actually attenuates the development of LVH. So for example, in a small case control study of about 40 postmenopausal women receiving and not receiving hormone therapy, treatment with hormone therapy resulted in a 20% decrease in LV mass. Animal studies have also shown that treatment with estradiol in overrectomized mice led to the improvement in LV diastolic function. So what are the mechanisms by which estrogen is really purported to attenuate HFPEF development? This schematic represents 6 key regulatory mechanisms of estrogen on biological processes that contribute to the development of HFPEF. And as you can see here, estrogen reduces oxidative stress, reduces endothelial dysfunction and inflammation. It also inhibits the activation of the renin-angiotensin-aldosterone system. It increases natriuretic peptides, and it attenuates fibrosis. So loss of inhibition of these pathologic processes due to the decline in estrogen during menopause is really thought to contribute to the development of HFPEF in postmenopausal women. Now, our mechanistic understanding of the relationship between sex hormones and cardiac remodeling is really rudimentary. And what it highlights to me is that there's a very important unmet need to systematically assess the association between menopause-related estrogen decline and the development of HFPEF. So we're trying to do that by interrogating one piece of the story. We are examining changes in inflammatory pathways through the menopause transition. We've just launched a research study here at MGH to investigate longitudinal trajectories of systemic and endothelial cell inflammatory profiles through the menopause transition in women at risk for developing heart failure. And we'll actually be examining 3 specific inflammatory readouts. First, we'll be looking at endothelial cell gene expression profiling. Second, we'll look at inflammatory biomarkers through proteomic profiling. And last, we'll be looking at pro versus anti-inflammatory eicosanoid metabolites. And I'm particularly excited about this project as it leverages a really novel protocol that's used to isolate fresh human endothelial cells for transcriptomic profiling. We'll be applying this technique, which has been done previously in diabetic patients and other populations, but to an entirely new patient population to provide mechanistic insights into the changes that occur during the menopause transition. So how do we put this all together? As we've reviewed together today, conventional and female-specific risk factors predispose women to HFPEF preferentially, and this may explain the greater prevalence of HFPEF among women. And then once HFPEF develops among patients with HFpEF, the clinical phenotype seems to significantly differ in men compared with women. And this is characterized by more abnormal diastolic function, lower natriuretic peptides, worse exercise parameter, and reduced quality of life in women. But interestingly, better clinical outcomes. While HFpEF specific therapies are limited, which highlights a very important therapeutic gap for women with heart failure, there have been hints that women may actually preferentially benefit from MRAs and ARNIs. And finally, do sex differences in immune activation drive the sex heterogeneity that we are observing in HFpEF susceptibility and disease phenotype? And does menopause and related estrogen decline contribute to an acceleration in systemic inflammation and HFpEF pathogenesis in women? Questions that are active on our minds. So to summarize, traditional risk factors like hypertension, diabetes, and obesity, along with female-specific risk factors, including preeclampsia and infertility, predispose women to HFpEF. Second, women with HFpEF have worse symptoms, worse responses to exercise, and worse quality of life, but better clinical outcomes compared with men with HFpEF. While HFpEF-specific therapies remain limited, there's been suggestion that women with HFpEF may actually derive preferential benefit from mineralocorticoid receptor antagonists and angiotensin receptor neprilysin inhibitors. And finally, systemic inflammation and estrogen deficiency may explain the female susceptibility to HFpEF. I'd like to end by acknowledging the incredible research team that I get to work with here in Boston, including my primary research mentor, Dr. Jennifer Ho, and my co-mentors, Drs. Markella Zani and Naomi Hamburg, as well as my clinical partners in the Corrigan Minahan Heart Center Women's Heart Health Program, including Drs. Melissa Wood and Nandita Scott and many others. And I'll be happy to take any questions at this time. Thanks again.
Thank you, Dr. Lau, for that amazing talk. It's a really excellent overview. I had one question. So you did mention that there's significant differences in symptoms and echo parameters between males and females with HFpEF, but similar, actually better outcomes for the female cohorts in many situations. Do you think we should have like echo parameters that are sex specific in evaluating patients with HFpEF, or do you think that's not something that's useful?
Yeah, thanks so much for that question, Chris. I think the concept of even sex-specific cutoffs for biomarkers, echo parameters is a really interesting one. I think that the short answer is I think we don't necessarily have enough data to apply sex-specific cutoffs in general, like sort of writ large. But I do think that there's a really interesting consideration of whether or not ejection fraction cutoffs in men and women should actually be different. I think I started to highlight that a little bit in the data that I showed. But is it possible that the reason that we saw in post-hoc analyses that in Paragon HF that sacubitril valsartan women seem to derive benefit from Entresto and men did not? Is it possible because we are actually capturing women who are already starting to develop some degree of systolic dysfunction at an EF cutoff that we typically consider to be normal? So that I think is a really interesting question. We don't fully understand yet. We know that EFs are generally higher in women than men, but are we actually starting to see that the physiology and cardiac remodeling is different at different EF cutoffs? So I think that's probably an area where I see sort of the first possible clinical translation.
Thank you. That's very helpful.
Hey, Emily, it's Beth again. Fantastic talk and congratulations on all the amazing work that you've done. Especially I'm very interested in the exercise data you have with several hundred patients you have enrolled who have had invasive CPETs. That's really just truly remarkable that you're able to have collected so much data. The one finding I found interesting among many was the peripheral oxygen extraction that seem to be more impaired in women. It's fresh on my mind because in the long COVID population, that's something that we're seeing too, albeit the long COVID population having a higher prevalence of women too. Presumably that's from endothelial dysfunction potentially, but I was just curious if you had any insight as to what may explain that finding in your studies.
Yeah, I mean, I think that that's such, that's like the key point, right? Why are we seeing, for example, so many more hemodynamic abnormalities in our women patients with HFPEF, even though functionally they're actually similarly limited, like their percent predicted VO2s are quite similar. I think what I hypothesize is that the sort of vasculature and sort of extra cardiac drivers of our overall exercise capacity are probably more central to women's pathogenesis of HFpEF than it is in men. We know that HFpEF isn't just a condition of the heart, that there are issues, you know, like as you say, peripheral oxygen extraction, skeletal muscle, et cetera. And is it that the vasculature, like arterial stiffness, endothelial function, are those things even more abnormal in women, which make them not only more susceptible to developing HFpEF, but once they have HFpEF, more likely to develop symptoms like congestion that we're seeing in sort of these clinical trials. And I think it's really interesting that you mentioned that you noticed this in the long COVID population, because the prevalence of long COVID is so much higher in women, and we just have no idea why that is. And is it there's something different about you know, our endothelial function, our vascular function, arterial stiffness in women compared with men? I know, you know, Jen Ho, my primary research mentor, is also doing a study now to look at endothelial function and coronary microvascular dysfunction in patients with long COVID. So maybe we'll get some answers.
That's fantastic. And one additional question too was that's really interesting that you're planning to collect endothelial cells in your study. I was just curious as to the yield of endothelial cells you get through that method too, because I think it'd be really exciting if we could do these endothelial cell biopsies on patients without needing tissue. But curious if you've started that study, and if so, how your yield has been on those collections.
Yeah, they're tricky. They're, you know, the yield is variable. And, you know, we sort of looked at our prelim analysis for something else where we collected endothelial cell biopsies. And you have to be thoughtful about how, like, for example, we collected endothelial cells in HFpEF patients and tried to look at RNA sequencing. You really do have to be thoughtful about how you're extracting the RNA, because you're not getting as many cells as you would have just like from plasma, for example, or PBMCs, for example. But in general, if the procedure is done well, and it's not that hard to do, the cell yield is reasonable. Like, it's thought to be like good enough for us to be able to get reasonable transcripts when we then send it for bulk RNA sequencing. But as you say, it's really nice because it's pretty non-invasive. You put in an IV kind of semi-sterilely, and then you just run a wire back and forth and you get cells, which is, you know, a lot of participants are willing to consent to that.
Yeah, and potentially even, you know, in the cath lab, you know, with the arterial sheets we put in, you know, and wires we put in every day, is this an easy way to get samples from discarded wires and sheets that we use every day in our patients? So it's definitely a cool method.
Yeah, that's a really good point. We did try actually initially to send the PA line tips for another study. The yield there was not great, but we weren't necessarily like scraping anything. We just sent the tips over. So one presumes that many of the cells had like washed off.
Thanks so much, Emily.
Of course. Nice to see you, Jeff.
You too.
Hi, Emily. This is Greg Fonra. Thanks so much for that really terrific talk. I was wondering if you could share some additional thoughts with regards to SGLT2 inhibitors, because it is so striking for the heart failure, mildly reduced and preserved EF patients between men and women. There really were such strikingly similar efficacy for primary endpoint and really the components of that, as well as safety and tolerability, and even quality of life changes. So what are your thoughts? Is it just the multitude of different mechanisms by which SGLT2 inhibitors are working, that they're overcoming some of these sex-based differences in a way that say MRAs or sacubitril valsartan are not, where it's blurring what could still be meaningful differences in the pathophysiology?
Yeah, I mean, I think that's such $1 million question. And my hypothesis really is that, just as you say, that the mechanism by which SGLT2 inhibitors how we derive therapeutic benefit from SGLT2 inhibitors is probably not sex biased, in contrast to something like Entresto, where we think that probably cardiac remodeling is quite different between men and women. But we really don't know. We don't, I think often when you see, oh, they're the same, then people aren't that interested in looking further. But I think, as you know, of course, Dr. Fonera, that we don't even completely understand all of the mechanisms by which SGLT2 inhibitors provide therapeutic benefit in our HFPEF patients. So trying to tease that out first, and then trying to better understand, are those actually sex agnostic? Like there may not be differences in the way that works in both men and women.
Okay, Dr. Lau, thank you again. If there's not any other questions, we want to thank you again for joining us for Grand Rounds at UCLA, and we really appreciate you taking the time.
Well, thank you. Thanks so much for having me.
All right, have a good weekend. Thank you again.
You too. Take care.